Hi, and welcome to Inspiring Each Other. I'm Dr. Phil Worth, and tonight I'm here with Dr. Bryan Henry. He's a board certified cardiologist who is going to share some of the future of cardiology and where we're going with prevention and what is on the forefront. Dr. Henry, welcome.
Well, thank you, Phil. It's great to join you.
When I started training 20 years ago, I can remember cardiologists telling me that in the cardiac ICU, they would literally watch people die. They would come in and monitor things and just be really unable to do anything about it. Um, did you have some of that experience? And then where do you think we're going 20 years from now?
Well, I've been in practice almost 20 years, and right at the end of my training before I came into practice, the cusp of that had just changed. So I know some of my senior partners had shared similar stories where, people had come in critically ill from an active heart attack, and the interventions were limited. And so oftentimes it was more monitoring and supporting as best you could, but you weren't providing some definitive intervention. And, those days have long since changed. I mean, there's still a subset of people that have sudden death, unfortunately, that don't have any time to intervene on. But most people that come to the hospital that are having active heart attacks can get definitive treatment fairly quickly. And, they can be up on the floors reading the newspaper after their stent, and you wouldn't know that they just had a massive threatening heart attack because it's been aborted. So, but in answer to your question, I mean, we've both been doing this for a long time. And just in the last 5 years, I think we've both probably noticed that there's a lot of change afoot. There are medicines that, we weren't even trained on that are mainstay and now. And even 5 years ago, there weren't as many medicines as there are today. Diabetes, certain type of cholesterol meds, which I'm sure we'll talk about. So, that's just in the last 5 years. If you ask me 10 to 20 years from now, another decade or two of advancement, I think we're going to enter an era of real precision medicine where we can really identify risk in an individual patient specific to them, what their risks are, instead of just kind of a generalized risk score. We'll have the imaging and diagnostics to pick it up in a very early stage. And then we'll have some really, custom medicines suited to an individual person that can make a difference. So it's an exciting time.
Right. Awesome.
Right.
For me, when I started, and we're talking a little bit about cholesterol, early in my practice, it was all about LDL. We're post MI or prevention or primary prevention, secondary prevention. We're always looking at the LDL. And then as I started practicing in, I don't know, 2012 or 13, all of a sudden there was these calculators and risk models. And now we're talking about totally different cholesterol molecules that I didn't even know existed really when I was early on in my career. So walk us through some of that as you've experienced that change.
Well, I think similar to you, we had and we were all trained the same. So, we had a very simplistic understanding of cholesterol and, how fats and lipids are managed in the body. There's nothing inherently bad about it. Cholesterol is a necessary, molecule that helps with steroid production, and a lot of the lipids and fats that, we eat and produce are necessary for cells and normal functioning. So historically, we had always broken it down to a very simplistic, the good, HDL, the bad, LDL, and the triglycerides, these three big categories. And, I think that's all we knew at the time. But as the biochemistry has really played out, we start to understand these molecules in much more detail and, how to really refine, not all bad cholesterol is created equal. Some LDLs are much worse than others. Some HDLs aren't as protective as others. And so that's where the science is really heading. I think if we're talking to try to educate people, and it's in its simplest forms, it's worth understanding, what what cholesterol is, and what these particles are all about. So, we all need fat in our diet. It's triglycerides and phospholipids and different things are important for energy in the cell. and cholesterol as well. But just like a drop of oil in a glass of water, it's not soluble. They separate out. If fat was and cholesterol and lipids were just floating around in our bloodstream freely, they would be just like a drop of oil, and they would go immediately into a small vessel and they would block it the instant you ate it. So the body gets around that by making particles that package up these molecules. We call them lipoproteins. So these particles are little packages that allow the fat and cholesterol to be in the center of them. This particle dissolves and it can be transported safely in the blood to the cells and tissues. So LDL is an example. That is a package, a small particle that is packaging cholesterol coming from the liver, and it gets delivered to a cell where it's needed. HDL is another particle. It packages and kind of pulls the cholesterol out of the tissues and the blood vessels, brings them back to the liver for recycling. And there are a number of other particles like that. So LDL, even though it's the bad cholesterol, it's not bad. It's a particle that we need to transport the cholesterol to the cell that needs it. The problem lies where if there's too much of it, or if it's not processed correctly, or if there's inflammation that kind of makes it sticky, then it can build up in vessel walls. I brought a picture here. I'm not sure if this will, project well, but, so if this is a picture of two different particles. So this is an LDL particle. It's a little spherical particle. The cholesterol and the fats are on the inside. LDL is mainly cholesterol on the inside. But there's an outer layer of it that allows it to be soluble. And there are proteins, different substances, different molecules that are on the outside of this particle. And those proteins are critical for it to interact with cells. So a protein is like a kind of a hook and a key. So as this particle gets to a cell, it somehow has to communicate with the cell to say, I need to go inside this cell. And the protein is what kind of is the key to get into the cell, because there's some receptors on a cell, and it interacts with a specific receptor, and in it goes. So there are different proteins on these particles. So on LDL, there's something called apolipoprotein B. It's a common protein. It's a very important protein. It's not by itself pathologic. There's one of these proteins for an entire LDL molecule. So when you talk about some of the other markers that we're now looking at, so there's this LDL, but it's the cholesterol inside it that's harmful if it accumulates. But not all LDL is the same. There can be bigger LDL particles and there can be smaller ones. So I can check your LDL cholesterol and you can have a certain concentration of it. But if it's made up of 5 big particles, that's the same amount of cholesterol as, say, 10 smaller particles. But the 10 smaller particles are much more atherogenic. They're much more likely to cause disease if you have a lot of these particles, bombarding a cell, as opposed to maybe a fewer amount of large ones. This ApoB protein, there's 1 per particle. So it's a better count of how many particles are in the body. It's not the cholesterol itself. It's this ApoB is just a marker. So it's saying even if your cholesterol between 2 people is the same, if your ApoB number is higher, that person has more particles floating around and higher risk. So the ApoB is starting to become a better marker of risk. It correlates with risk more than just the total LDL concentration.
So as we, to pause just in the middle of that, and I'm going to let you get right back to that part. I never measured ApoB, right? It's been, a year, 2 years that I've been measuring ApoB. How long have you guys in the cardiology circles been looking at measuring an ApoB?
So to be honest, I've been a slow adopter of it because, LDL still concentration still performs quite well. And ApoB is similar to to LDL in terms of, how the risk scores are calculated. It is helpful if you know someone is really high risk and you've got their LDL concentration to our target. But if their ApoB is still very high, you might say, hey, you need more statin to bring that down. I don't think anyone, though, has convinced me yet, and certainly the guidelines aren't quite there, should we be using the ApoB to titrate our statin? I think it makes sense to, but in terms of what number to go to, it's still a little debated. So I still use the LDL personally. But in people that are, still, if they have a secondary event, despite their cholesterol being at the goal that I thought it should be, then it might be helpful in that situation to say, hold on, this is a subset of person that still has a very high ApoB, and I may, really try to increase cholesterol meds in that person.
The other molecule that we were talking about is sort of an LP little a, the lipoprotein little a. Did you want to sort of coach up
Yeah,
on
I
that
mean,
a
again,
little
if this projects or not, I'm not sure. But so if this is an LDL particle with its ApoB, a subset of LDL can actually have this second protein on it, this LP little a. And so this protein, though, unlike ApoB, which is, kind of a benign protein that it needs to communicate with cells, lipoprotein little a appears to have, some really bad stuff associated with it. So this extra protein here on the outside, is much more thrombogenic. It causes inflammation. It makes this LDL particle, much more likely to cause disease. And, science has come to appreciate that it's very common. Probably 20% of us have LP little a. It's genetically based. There's nothing you can do exercise-wise or diet-wise to change it. It's pretty much is what it is by the age of 5 even. So if someone has a really high family history and their regular cholesterol numbers actually look surprisingly normal, 20% of people have this LP little a gene, and that may be why they have higher risk of disease.
And so if you have someone, I'm handsome but 50, Dr. Henry, I'm growing up finally, 51 actually. So if my LP little a is elevated, and I'm doing all these other things, and my LDL is 80, what do you do with a guy like that, or how far are we digging? How aggressive are you going to be?
Well, unfortunately, if you ask me that question now versus 5 years from now, the answer is probably different. So right now, there's nothing that treats LP little a. It's, like I said, genetically based. Statins don't lower it. Exercise doesn't lower it. A few things do lower it. Niacin, B vitamin that we used to use for high triglycerides and low HDL.
Yeah.
You may remember 10 years ago, we were giving niacin for those people. That never showed benefit in terms of outcomes, so we don't use it anymore. But interestingly, it does lower LP little a. Estrogen can lower LP little a. But we all know estrogen, doesn't prevent, that we stopped doing years ago.
Yeah.
These other agents, PCSK9 inhibitors, some of these injections do lower LP little a, and that may be an avenue for treatment. But there are a handful of drugs that are really close to, pretty advanced trials that may be approved, I think, in the next several years that specifically target LP little a. They work at a very, basic genetic level where you can block the production, the RNA production of this protein. So you can really lower it at the cellular level. The question is, will they reduce risk? And that usually takes 10 years of randomized trials to figure it out.
Where with this, so now I understand a little bit better, and hopefully other people do as well, the differences between these molecules. I've been checking them, not consistently, but a little bit more, and I think some of it is out of curiosity, especially in high-risk individuals, just wondering. When we start talking about these coronary calcium scores and CT angios for screening almost, right? We're not really looking to detect an event. We're finding a high-risk person and doing advanced testing. Where is that in your mind?
So I do use calcium scores more than I did just 5 years ago. So, a calcium score is a CAT scan based score where, a CAT scan, when people are going into the tube, a sophisticated X ray type machine, where, you can image much more than a chest X ray. You can image, three-dimensional structures, you can reconstruct them, and you can look at vessel walls. Um, Calcium tends to deposit where there's plaque buildup. So, if we can image a vessel directly and see the earliest forms of plaque buildup, then that does change my management of people. Some people that you think are low risk, a picture says 1,000 words.
Yeah.
You suddenly have a picture in a 50-year-old whose cholesterol is normal, but let's say had a strong family history. I am doing calcium scores on those people because I don't necessarily trust, the risk score calculator. There's a genetic risk here that I can't measure. So let's get a picture. And so the calcium score can help that. And it's, graded for your age. So everyone gets a little bit. As we get older, it'd be surprising if people have 0 calcium scores at 80. But if at 50, you're in the 90th percentile, you're way off the charts for your age, then there's something in the background causing atherosclerosis, and that changes how I approach it.
Do you do it in younger people? So when we talk about these risk calculators that I've used, some of them don't start until the age 40.
Mm-hmm.
If I have a guy whose dad had an MI at 49, where do I go with that part, right? What am I testing someone in their 20s and their 30s? How aggressive are you when you manage that?
So that's a good question. I think, I generally test when I think it'll change my management. So I certainly wouldn't do a calcium score on someone that has known disease. And I generally don't do it unless people have an academic interest, personal interest to know. I don't do it in someone who's on full dose statins and their diabetes and blood pressure well controlled. I'm not going to do anything differently, so I don't always look. Nor is it paid for. It's a screening test that generally is out of pocket. Insurance doesn't pay for it. But in that 40-year-old that has a strong family history, but normal cholesterol, I would do it. And I generally would consider doing it around 40. Studies would show that the earliest plaque buildup occurs probably in our 20s. If you actually, here's another model that may be helpful. I don't know if this zooms in or not. So,
Paul, can you make that pretty? Oh,
there
there
you
goes
go,
Paul.
Paul.
Well done, Paul.
Paul, that's where the magic happens. There you go. So, this is a cross section of a blood vessel. And if, we're all born with a wide open pipe, there's a lining of a blood vessel called an endothelium. And this is how blood interacts with, with the vessel itself. There's a wall of the vessel, though. And this is, this wall is made of muscle and a few other things. And as we get older, as cholesterol and, different bad actors are flowing through the vessel, plaque can start building up in the vessel. So this yellow representation here, this is a little plaque buildup in the blood vessel wall. This plaque starts at a very early age, and certain people earlier than others, but you can see this plaque or fatty streaks, we call them, in people in their 20s. Certainly if you smoke, it can be sooner. If you have diabetes, family history, probably sooner. It's probably not going to be advanced until you're, even with risk factors, till you're in your 40 range. But, as the plaque slowly builds up in the vessel wall, it can eventually, block the vessel. So there's hardly any space left. And, that's what people think of as causing a heart attack. That's not what causes heart attacks. And this is really important for people to recognize that heart attacks are not caused by cholesterol slowly narrowing that vessel to nothing. Heart attacks are caused by plaque rupture, where this cholesterol plaque kind of ruptures. The cholesterol is kind of squirted into the blood pool, and a clot then forms on top of that. So what was once, 50% is suddenly 100%, and that's what causes a heart attack. This is why stress tests have limitations. Stress test isn't even looking at this artery. Stress test puts someone on a treadmill, gets their heart rate up, tries to see if they can get the muscle. The heart is over here. So this blood vessel is supplying heart muscle. And if this heart muscle doesn't get enough blood, you get chest pain, your EKG changes, your image changes. Stress tests are going to pick up this problem, the severe narrowing problem. They're not going to pick up this 50% problem because the heart still gets all the blood it needs. And so, if a stress test can be totally normal, people can have heart attacks the next week. And I've seen this time and time again. Like, but doc, I had a normal stress test last month. Yeah. So a stress test tells you about your symptom. It doesn't tell you if there's disease in the vessel. The CAT scan, though, looks at this vessel wall, and calcium ends up building up in there in advanced plaque. And you can then say, yes, there's disease in this vessel, whether your stress test is normal or not. But what it doesn't tell you is if it's actually blocked. It's just how much calcium buildup is in the vessel, and it tells you that's your burden of disease.
When, going back to the old days, I would talk to guys that started doing caths, and they would say, oh my gosh, if you could see the vessels before statins, everybody was on them, and see vessels after they were on statins. Could you describe that a little bit?
Well, certainly, statins, of course, most people are familiar with these because, they're ubiquitous and they're our mainstay of treatment. So they inhibit production of cholesterol at the liver level. And, we have seen, dramatic effects, just population studies in my 20 years. When I was in training, we were seeing MIs just rolling in the door. And in 20 years, an ST elevation MI, when there's complete blockage of the artery because of this plaque rupture phenomenon, those are much less common. There's probably 50% reduction over the last decades in that. And that's because statins not only reduce the cholesterol plaque buildup, but they also prevent plaque rupture. So even if your cholesterol is normal, statins have been shown to reduce heart attack risk because they prevent that plaque rupture.
I get a lot of feedback about, there is so much lay press that is just insanely negative about statins, right? For obvious reasons, right? They're not perfect. How do you handle that when you're talking to a patient who just is, I'll use the word anti?
Yeah. So I think, at some point we have to be pragmatic about what we can offer too. So, if I had nothing to offer, then, the risk benefit is 100%. But, statins have clear benefit. Their risk, like any medicine, is there, but they're among the safest medicines we use. And, yes, some people can get muscle aches with it as the main kind of nuisance side effect. Severe reactions to them are extraordinarily rare, and some studies show no different than even placebo. But yes, they've had their rap. But if you look at all the studies combined, where you randomize people with heart disease to statins versus placebo, kind of an inert pill, the statin group always does better in terms of heart attacks, strokes, even longevity, life expectancy in certain subsets. To your point, though, that data is best for secondary prevention. So if someone has had a prior heart attack, or you document that they have disease in the vessel, then the number of people you'd need to treat to prevent a heart attack is much lower than if I just gave it to someone that has slightly elevated cholesterol but no disease. So for primary prevention, someone that just has slightly high cholesterol but no disease, I generally don't use it until they've exhausted diet and exercise, of course.
When I listen to some of the stuff that I listen to and read about, they'll talk about, LDL cholesterol levels of 40 and 50. And when I trained, there was the 70 benchmark. And then everybody should have been on a high dose statin. And some of these guys were talking about, why wouldn't we want everybody's LDL cholesterol to be around 40? Because there's going to be less events. Mm-hmm. Is that an honest jump when you start talking about this, or maybe not?
I think the jury's still out a little bit about, is there too low? Yeah. From a vascular standpoint, probably not. From hormone production and brain cell function. It probably is. I mean, we all need some, lipid concentrations and cholesterol. So, but, when you look at the hard data for cardiovascular disease, the studies keep showing lower and lower is better, you know. So, and some of our drugs are definitely pushing them pretty low. Um,
Talk a little bit about, CT angio. There are some guys as in my world, I'm talking to people about these things, and there are some doctors out there saying everybody should have a CT angio. Why wouldn't you want to know exactly what's going on
mhm.
with your blood vessels, whether you are high risk or low risk? Wouldn't you just want to know? What would your take be on that?
So, I mean, most screening tests, in my opinion, you have to weigh, what you're going to do with the information. So, with the risk of the test itself, so a calcium score has very little risk. It's the equivalent of maybe, you know, 10 chest x-rays. A chest x-ray is the equivalent of a mammogram, and that's probably the equivalent of, you know, 10 days of cosmic radiation.
Right.
So
Radiation exposure is what you're
radiation
talking
exposure.
about.
So, a calcium scan is pretty low radiation. Once you do a coronary CT scan, that's a much more sophisticated type of image. It requires contrast. So that's an agent that we give in medicine for most of our imaging that, you inject into a blood vessel. It outlines the blood vessel. It goes throughout the entire body, kidneys included, and the kidneys don't love contrast. Um, and the CAT scan itself to generate pictures of the whole length of a blood vessel, is probably 100 chest x-rays. So, and there are different protocols to get it less, but standing in front of a X-ray machine and pushing the button 100 times may not always be the wisest thing to do. So you have to pick and choose who you do it on. But the imaging, when you talk about what's going to happen in 10 years, I have no doubt that CAT scans are going to be much more widely used. If the radiation protocols come down and we can get around some of the contrast stuff, there's definitely ways that it can measure flow through the vessel. So it might even eventually surpass stress tests in sorting out a symptom.
Mm.
But as of now, it's still just it's a picture. It doesn't tell us about a symptom, which is half the time we're using it. Is that the cause of your chest pain? I don't know. I might, you might find disease, but it doesn't mean it's the cause of your chest pain.
It gets complicated, and I think when you have one bad event, when I have a poorly controlled diabetic that goes in for a cath that goes a little bit too long and ends up on dialysis afterwards, because that was the penultimate hit to her kidneys in the middle of her MI.
Mm-hmm.
Um, that's risky, right? That's scary for these
Yeah.
people. And so how do you express that when it's just one of thousands of these things that we could potentially order in the future? And I think it complicates the story.
It does. And like I said, the risk benefit, if you're going to do something different with the information, I don't want to scare people away from CAT scans. I think, sometimes the information is far more important than the actual small risk I've talked about. If it's going to change what you do and, alter medication choices that then improve your outcome, it's definitely worth doing the test.
Um, if you had a little bit of time to sit down with someone, the chubby 50-year-old guy that's a little worried about his future, right? What's the perfect way to approach non-medicine, right? What are the things that you try to tell your patients about really primary prevention, right?
Well, as I'm sure you do in your practice, as well as your kids,
Yeah.
you gotta start with the basics. Everything we just talked about, the advances of medicine, that'll never compare to healthy lifestyle. If you look at the data about all these medicines, when you look at the absolute reduction in risk for almost any medicine in cardiology, oftentimes, we're talking between 2 and 4% risk reduction. So cumulatively, that makes a difference. But that's nothing compared to the benefits of exercise and a healthy diet. So when I engage patients, I always start with diet and exercise before we jump to all the medicine stuff. And diet, I think most people, understand, what's healthy and what's not these days, whether they, you know, decide what to, to eat the healthy stuff is a different story. But, um, we can talk a little bit about, what you recommend to your patients in terms of diet, as well.
It's I think it gets complicated because you get burnt out when you've talked to someone that has made bad food choices, and quite frankly, I don't necessarily think it's an individual's fault because society throws so much stimulants at us about Doritos and McDonald's and every commercial. You can't get away from it, and you can't help but kind of like and want to consume that stuff because it's addictive. And so it really complicates the conversation. And I think we get overwhelmed because we've had the conversation 4,000 times and people don't make the change.
Mhm.
And I think patients on the other end of that conversation just feel judged. One of the things in my world that has been, these GLP-1 medications, and we talk about, slowing GI motility, but I think there's something that has to happen to brain chemistry. And I'll hear stories from one of my big giant guys. Doc, I take that GLP-1 every time except for when Bills play on Monday night. I skip my dose because I don't even want to drink 2 beers if I've been on that. And if it's a Bills Monday night game, I want to have 6 beers,
Right.
And so there's something going on that this guy doesn't have the same pleasure from drinking a handful of beers when he's on a medicine as to when he's not.
Yeah.
And I think that stuff will be a game changer when we talk about diet and exercise. But I always try to go back to the Mediterranean stuff, right? You got to exercise 30 minutes a day. You got to get on that Mediterranean diet. You got to pay attention to your numbers, right? And I imagine it's very similar for you.
It is. And I think we actually, I don't know about your training, but I would say that, standard medical training in my era didn't do a great job with diet.
Yeah.
We knew the basics of the chemistry I told you about with fats and carbohydrates and proteins and things. But when it came to, how to really educate people on healthy diets, I don't think they actually knew until, you finally really honed in on things like the Mediterranean diet and such. And nor do we have the time in a busy, schedule to really do a service for the diet. My wife's who's a cardiac nurse spends an incredible amount of time when she does an intake on a patient, really teasing apart things like diet and exercise program. And I honestly think that does a much bigger service to a patient to spend an hour teasing apart their diet and where you can nudge it in the right direction than the 5 minutes where I say Mediterranean diet, I give them a handout,
Yeah.
and
See you in 6 months.
right, exactly.
For me, I think there's this complicated world out there of, and I'll use the word functional medicine, right, where people are digging into diet and what we're putting in and doing a wonderful job, much better than we've ever done and we're ever trained how to do. But on the other side of that coin, oftentimes they poo-poo the medicines that might be saving lives. And I think where we need to go with both of this is how do we meld these two things together so that people who need the statin understand and are willing to take the risk, but at the same time aren't eating Doritos and chips for every single meal.
And, people have to understand that small interventions can make big differences. So someone that comes in morbidly overweight, they're in a difficult position. And, I sympathize with them because it's easy to say, here's some diet recommendations and walk. But if your knee arthritis is killing you and you can't breathe because you're short of breath and, and you're hooked on certain food patterns, we both know which patient is unlikely to succeed without the help of medicine. So these GLP agents, for instance, as long as they keep playing out the way they are, I think they definitely have a role.
It's for me, it's been an exciting time because I feel like things are really changing.
Yeah.
This is going to be a whole new world 5-10 years from now.
Absolutely.
And I hope that I'm young enough and energetic enough to keep learning and not old and retired, right? As we all tend to grow old and things happen. Any other thoughts? Anything we missed? Anything else that you want to share with people about their cardiovascular health?
I think as much as we talked about some of the basic science and what we do on a day-to-day basis, if people really want to empower themselves to make a difference in their own life, they have to look at kind of the big picture. I always tell my patients that, want to spend time about, life coaching more. And if I'm not talking about the med as much as lifestyle, to encourage people to look up the blue zones, which you might be familiar with. So there are certain geographic regions in the world that have low chronic disease, lower cardiovascular disease, higher likelihood of, making it to 100. And, if you don't need a randomized trial to say, try to emulate what those people are doing.
Yeah.
And, there's lots of stuff you can look at for that. And, if people go to blue zone type websites, you'll see that they have a lot of things in common, these communities. Much of it, of course, is diet-based. A lot of plant-based diet, whole grains. Animal products are okay, but smallest portion on the plate. They all have active lifestyles. Activity with purpose. They're not kind of waking up and going through the grind as much as pleasure in life with gardening and play pickleball, whatever your thing is. And then there's a lot of social engagement in those communities. What we tell our kids, get off your screen, speak to a human, pick up the phone, call someone, play with a friend outside. All that stuff makes a big difference. And these blue zones, that's the life they live. They're very socially interactive and support each other.
It's, looking at a lot of that stuff that they've just done it their whole life, and when you watch some of these documentaries, I will see a 90, 100-year-old lady squatting down in full flex knees, eating off a table or playing with her grandkids.
Yeah.
And she can do that because she's been doing it every day for 50 years. And in our culture, we have become so sedentary, a lot of us. And quite frankly, it's not always our fault. The world is easy, right? We don't have to garden. It's just everything we want is thrown at us. And all of a sudden you wake up one day and you can't. And how do we get people to make those changes a little bit earlier? And sometimes they don't see me, right? So in the primary care world, you come in every year until, I don't know, 18, 19, 20, 21, and then we don't see you in the doctor's office until you're 30 or 35, or when something goes wrong. All of a sudden you come back in and you're 80 pounds heavier than you were when you left for college. And is that the same sort of thing that you will see in your world with weight and people growing up?
Oh, sure. I mean, so much of, behaviors are just cumulative, repetitive things. And so, I encourage people to just take baby steps. It's discouraging if they come in and you just say, okay, stop smoking. Here's a diet that you probably have never tried and maybe won't like. And at first, everyone can grow to palate these things. But, if you're used to kind of greasy chicken wings and, pizza all the time, and suddenly I'm saying, oh, here's a rice and bean kind of mixture that, so you got to pick a few low-hanging fruits. I always say to them, look at your diet. We all know the basics that you should do. Pick one or two things that you think you could do without. Start there. Same with exercise. You don't have, no one in the blue zone joins Bally's Health Club. They're all just going out there and walking 30, 40 minutes a day. So.
And I think, when people ask me about diet, oftentimes I'll say, whatever fad diet you can get into, right? Whatever gets people into paying attention to what they consume instead of just consuming. They may not be perfect, but if you're passionate about it, I know I'm going to start to move that needle. And then as we start to move the needle, now we can address, well, maybe this would be a little better. Let's try to make this small change.
And portion control, of course, is a big part of it too.
It is.
My wife is great with this. She's like, no one should have seconds. You have to just eat slower. Because your brain isn't alerted that you're full until 20 minutes after you've had seconds. You could be full after first. Drink a glass of water and you're good.
And it's hard for us to learn that, right? It's got to be a testosterone thing because I'm always famished, right? The women won't want to eat. I tell my patients a lot, I start every day as a teetotaling vegan because I really believe that if I don't drink alcohol and I eat a lot of vegetables, I will feel better for the longest period of time. The hard part is I love a sausage, egg, and cheese, and I love a classic Cabernet. And how do we balance that without being all or none.
Mm-hmm.
It's just hard, right?
Yeah. I mean, I've done the experiment on myself, actually. I'm not a vegan, but I went vegan for 3 weeks. So I checked my cholesterol. This was a couple years ago, right after the holidays. Like, all right, the gravy train is over. Let me see, let me see what my cholesterol is. And sure enough, it was actually quite high.
Yeah.
I have no family history. I wasn't overly concerned, but I said, all right, let's do an experiment that I could talk to my patients about. So I went vegan for 3 weeks, and I had an LDL of, I think, 150 almost. And I dropped my LDL to 90 in 3 weeks by by just going pure vegan. And, so I proved to myself I can make a difference.
Yeah.
I'm not a vegan anymore, but every time I, look at something I shouldn't do, I say, oh, just remember you can make a difference. So small steps.
It's and similar. I did my my labs in the fall, and my LDL was at 130, 140, and I want it to be better. And the hard part is my negative is that I'm a stress eater, right? So when I'm behind in the office and running around, and some drug rep brings, Tostitos, geez, I'm hungry and I might as well hoover these Tostitos,
Yeah.
right? It's a very negative thing for me.
Sugar too. I mean, people
oh,
underestimate just
It's awful.
processed empty calories,
Yeah.
but I'm convinced I can tell if if I'm on the run and I grab, dark chocolate I can tolerate. If I grab something overly sugared, the brain fog is there
100%.
within about 15 minutes.
100%.
Clear. So everyone should give up sugared sodas and drinks.
Yeah.
That stuff is no good. So.
I agree. They suck you in, right? I love a chocolate chip cookie.
Right.
But if you don't touch them, it's a little easier not to touch them.
Right.
I put continuous glucose monitors on a lot of my patients, and I personally have worn one for, I don't know, probably a month over the past year. And it was so interesting. I'm in Las Vegas while my daughter is playing in her college soccer game, and I've got my CGM on, and we go out to one of these delicious Mexican dinners, right, where all the Tostitos come, and I have 9 million Tostitos and a tequila and a glass of wine with dinner, and then some big giant burrito, and I'm thinking this is great, and then you feel tired afterwards. All right, the little bit of fog sets in, and now we start walking around the casino, and my CGM is alarming, right, and my sugar was 40, right, so postprandially, about an hour, all of a sudden I just drop. And it happens to you all the time when you don't pay attention to the number. Geez, I feel terrible. I wonder why I feel terrible. And it's because I really overindulged, and then the insulin release, and then I plummet on the backside.
Yep.
Well, why not try to keep that sugar steady by avoiding some of that stuff and just feel better?
Yep. And the simple things, I mean, the body's figured this out. I mean, don't underestimate a little bit of fresh air, a little bit of sun on your face. We're all living in our cubicles these days, and you just feel so much better with just those little interventions.
100%. Any other questions or concerns?
I think we've worked together for quite some time. I think you do a great job, Phil, and
thank you.
I think this is a great forum, hopefully, for people to take a little more stake in the game and be proactive. And if they Google some of the things we've talked about, they can go into their doctor's visits armed with some really educated questions. Figure out what their risk scores actually are even before they go in. And then they can really, have a stake in the game.
And I think as we were talking a little bit before we got going, right, the ChatGPT and the AI stuff, some of the stuff, if you put into the newer versions of ChatGPT, you're going to get pretty good answers to your questions. You might get completely wrong answers, but most of the time you're going to get pretty good ones. And to arm yourself with that information when you go in to have a conversation. And the hard part for you and I in our really busy day is we're going to have to take a little bit more time to answer those questions. And how do you manage all of that? And that's the complicated piece. But I think it's the future of medicine.
For sure.
Well, thank you so much, Dr. Henry. It's been a blast.
It's been great. Thanks.